angle. So I'm trying to tell you whether the wide angle offers any advantage over the conventional fluorescein angiography. Now here is the conventional fluorescein angiography. The top shows the 30-degree. When we started, we used to have 30-degree fields. Then we moved on to 50 degrees, and whenever we want to see more of the retinal periphery, we take multiple fields asking the patient to look down, right, left, center, and then prepare a montage to see as much of the retina as possible. So the traditional fundus cameras, they may provide images of the retinal periphery if we are directing the lens to the periphery. And if we look at some of the major studies, including the diabetic retinopathy studies, they use traditional lenses to take multiple photographs of the posterior pole, and we call them 7 standard fields. But believe me, you required a really good photographer with technical expertise to take those 7 standard fields, and it's not very easy. So when we moved on to 50 degree, we said, okay, instead of 7, we just required 3 fields and we do it. But still, there are some of the things which we would miss out because the whole retina requires 200 degrees. So even when we prepare a lot of montages, the best we get is 75 degrees. So you can imagine that we are missing more than 50% of the retina anyways, by even after doing so much of hard work. So what is this ultra wide field imaging all about? Right now it is a shift from seeing 75 degrees of retina to 200 degrees of retina, and we do have Optos right now, which is the first camera available that can capture 200 degrees of retina. And I have no financial interest with Optos. This is not, okay. This is how you see the angiogram. This is actually the autofluorescence. So what you can ask is, you can take these images, you can scan the entire periphery either in the video mode or in the still mode, and you can review at the periphery whenever you want to. This is the fundus photograph which you can take. The fundus photograph on Optos has pseudo colors, so you would see a lot of green tinge. It doesn't look the way the conventional photographs that we see with the other cameras. So sometimes you may have to combine it with the other cameras if you don't like to see the image like this. Or the fluorescein angiograph, which goes right up to the periphery, captures the area of the periphery which we were otherwise not looking at. So now let's see how it is useful to us. Now let's see in different etiologies. The first thing is in retinal detachments, breaks, and myopic degenerations. We all understand that these are the conditions which involve the peripheral retina. So we also understand that there was an era when we would spend hours and hours putting indirect on our head with red-green pencils, trying to locate the break, yelling at our residents for not being able to pick up the break, and it was not easy and it's not fun. So if you want to really document, this is the tool which gives you a very good offer for documenting, teaching, showing the patient where exactly what is happening, and from medical legal aspects. So I'm going to tell you all of these, how do we cover this. For example, you can see this picture. This picture might be taken by a technician, this picture might be taken by your junior doctor or this, but you cannot miss this retinal breakout here. So you can tell your fellow to do the laser, and you can actually monitor that the laser has been done and it's doing fine without putting the patient on indirect and to the discomfort of scleral depression by somebody who is learning. Similarly, if you want to document, you want to teach what joint retinal tear is, how it looks like, how it is reducing detachment. For example, this patient might be seeing very well because his fovea is partially attached. So to explain to the patient that half of your retina is torn is not very easy unless you show them this. So once you show a picture like this, he knows, what's happening. Or the conditions like which might be good for study. For example, this is the congenital hypertrophy of the RPE, which might be mistaken for a retinal tumor or something you want to document, you want to see for progression. So this kind of the peripheral is not very easy to do it with by preparing the montages. Sometimes you may have a patient like this, a diabetic patient, when you do the exam, looks like tractional retinal detachment, but when you look at the periphery, you realize there is a huge break sitting out there. It's not a tractional, it's a combined RD. So the prognosis for the surgery changes, because the moment you see a combined detachment, you know the prognosis is not so good. From the medical legal aspects, for example, this is a patient which had undergone a surgery, came back for follow-up, the retina was flat, the surgeon was not in the center when the patient came for follow-up, so the fellow examined him, but the fellow was smart, so he got the picture done. So 3 days later, patient comes back in the emergency and now his retina is detached. So the patient complains that since the doctor was not there, the fellow missed my retinal detachment 3 days ago. So I should have been treated early. But since we had this documentation, which is kind of good to know that what was happening. So then we come to the intraocular inflammation. It's again very good tool for the similar reasons. For example, this is a patient with Behçet's disease. This patient had received an infliximab infusion in the past, and then he came at this stage where we had to decide whether to give next infusion or not. Now we look at the convention. This is not really the conventional, but this shows that the amount of the area we would see with the conventional photography, which is about 60 degrees or so. This looks very nice. You do the fluorescein, it shows absolutely nice. So probably the patient does not need infliximab again, unless you look into the periphery. Now this area here represents what we do with the convention, and then outside the area here you see there is this patch of retinitis. And when you do fluorescein, this area is the one which we had missed out initially on conventional, and this is the area which is actively involved, which is showing active vasculitis. So sure enough, with this amount of the vasculitis, it is an active disease, so patient does need an infliximab infusion, because if we miss out on this and don't give him, the next time patient is going to come back with cystoid macular edema, with more inflammation, with more problems, which becomes even more difficult to tackle. This is a patient you can see here with some synechia and all. This is a presumed intraocular tuberculosis patient. He is on routine follow-up, anterior chamber is quiet. This thing out here looks fine till the time you see the periphery. So these are the areas in the periphery which are involved the most in tuberculosis. You see NVE, and probably we were having more and more of Eales disease because we were not able to see so much far periphery. And if we miss these subtle neovascularization, the next time we see the patients with vitreous hemorrhage. So when we say Eales disease has reduced, it is because we have become wiser and smarter, and we are doing laser photocoagulation to these peripheral area before they have a chance to bleed and develop vitreous hemorrhage. For diabetic retinopathy, actually the wide-angle angiography has led to change in the management strategies. For example, this is a picture here, a patient with diabetes, and this is what we were seeing. This is the conventional. This is what we were seeing, and we always said diabetes is the disease of the posterior pole. It was because we were not bothering about the periphery. But now with the wide-angle imaging, we are realizing that these patients have a more disease burden which is coming from the periphery but is involving the posterior pole. So when we say the posterior pole, it is the effect which we are seeing and not the cause. The cause is somewhere in the periphery. So this has resulted in some management strategy changes. For example, a patient of diabetic who looks very nice, maybe NPDR, but when you do a fluorescein, you realize there is whole amount of cystoid macular edema, there is NBE, and there is this whole lot of area which is non-profuse. Now, this is the area which is producing VEGF and that is causing the cystoid macular edema. But we are busy injecting more and more to treat this cystoid macular edema without bothering to take care of the source of the VEGF, which is somewhere sitting in the periphery. So now there is a thing about the targeted laser photocoagulation, and what is the targeted laser photocoagulation is that you see the area in the periphery which is ischemic. Instead of just putting 6,000 burn randomly all over the fundus, you identify the area. I will show you an example of this patient who's a 47-year-old male. He seems to be doing very well, adequately lasered and good PRP. We used to do so much PRP that we were looking for the disc pallor, attenuation of the vessels, ghost vessels. When we say it is a good PRP, and these are the signs which you see in retinitis pigmentosa, attenuation of the vessels, pale disc, which means we were doing the overkill. Now let's see this patient on angiogram. There has been so much laser to the retina which was profuse, but if you look at the areas which were non-profuse, which needed laser, probably these islands have been left. So now it is about TRP, and this is a little bit, old one, but we have our own publication come up in IOVS, where we have shown that TRP, which is targeted laser photocoagulation, only to the areas of ischemia is much better than doing the PRP, that is killing the entire retina. And this is possible only if you have an access to the entire retina on wide field. Coming to other peripheral lesions like this, some of the lesions like retinal angiomas which need screening. I don't know why this is coming. So you can see some of these retinal angiomas in the periphery, and many of these patients will not be seen always by a senior person or by a retina specialist. But if you can do images like this, you cannot miss it. Even if your technician has done the screening, you know there are angiomas in the periphery and the patient needs to be managed. So to ensure the optos image, optos means the wide angle. It is useful documenting the retinal detachment before taking the patient to operating room, so that from medical legal point of view we are able to document precisely what the patient has. As sir mentioned, we may draw anything, we may say it was PVR, but we have no way of documenting it was what stage of PVR, it was anterior PVR, because only the surgeon knows how difficult it is when it is anterior PVR. But now at least you can document from medical legal point of view that the patient was bad to begin with. And these pictures are very useful for explaining to the patient the severity of their disease, so that they can go back and then after the surgery you can show what you have achieved. And it's also useful for less experienced observers of the posterior segment, general ophthalmologists, and even the optometrists, because they can pick up the details like melanoma. Melanoma is not our problem, but the lesions which are sitting in the periphery and which are otherwise very, very difficult to reach. Thank you so much.